Arthur, how you doing?
Good.
Hey, Arthur, you need to come into the webinar. There's Tibia. Arthur, can you come in, please? Who wants to meet Arthur? Well, you can meet him after.
Hello.
Can you come in, Arthur? And Divya, I might be missing some people that need to come in the panel. So can you see the panelists from your webcast?
Okay.
Okay, so I see Simon. I don't. Simon's coming in now, which
Yes, he needs
is
to be.
important. He's
Yes.
coming in. Anybody else you can see on the panel?
Dr. Anita Jagatia, she needs to be made a panelist.
Okay, which one?
Anita Jagatia, ANITA.
Oh, Anita.
Yes.
Do you see her? I don't see her on the panel.
She's there as a chairperson.
Okay, I'll admit everybody. So, cover all.
Then Dr. A.K. Singh, he would be the another panelist.
Can you see him? Can you see him? Is he in the waiting room?
No, he hasn't joined yet. He'll be joining.
Okay, I can't let him
Once he
in
joins,
unless
I'll
he
let you know.
joins.
Yeah. Yes.
Arthur, I need you to come in. You can't.
I just call her. Just give me.
Okay.
Hello, good morning.
Good morning, Dr. Bashir. How you doing?
I'm fine. What about you?
I'm John Bennett, host of Neurosurgical TV. And
Nice to meet you.
here's Benita. She's from the Alliance.
Yes.
And I imagine Divya is going to moderate, correct? Okay.
Hello everyone. Hello, Professor Simon. How are you?
Hello. I'm fine, thank you. Thank you for having me.
Thank you for joining. I know it's a Monday morning, but still, thank you so much. Dr. Anita Jagatia has joined. Can you convert her to a panelist?
Okay. Okay, you're going to have to text that. Will you please text who needs to come in? Text me on WhatsApp or the chat. Please text me the people that need to come in.
Okay.
Okay.
I'll do that.
Yeah, we have to communicate. You can either do the chat or WhatsApp.
I'm sending you by WhatsApp.
Okay, that's fine. I can see you're typing. Yep. Okay, Anita. Okay, there we go. That's better. I can see that.
Yeah, hello.
And we don't have to start exactly on time. Don't worry about
Yes,
that.
yes. Just ask Professor AK Singh to join. Then
Okay, I don't see Anita. Nope, Anita's not there. Who else? Oh, Anita's in. Anita's in already. Okay, who else? Let me go back to the WhatsApp. Okay, AK Singh.
AK Singh,
Okay,
he's
good.
just joining. Just had a word with him. He's joining in a couple of minutes.
Okay, he's not here now. Well, let me give you. I'm going to give you the direct link. Okay, Divya. Give them this. This is a direct link in. You got. You got it there.
Okay.
Okay, if you want to give it to, because Anita's inside. Anita's here.
Okay.
Dr.
Okay, I've got
Singh.
it. I'll see whoever
Yeah,
joins.
that's a
Just
direct
forward
link
it to
if
him.
you want that. And whenever you want someone, just type them in. Say, please admit. Because
Yes, yes.
my
I'll do
hearing
that.
is not the best.
Okay, I'll do that. I think just a couple of minutes and then we can start. We
Yeah,
can start.
yeah. We don't have to start exactly on time. Are
Yeah.
we waiting for anybody crucial? Is anybody I'm missing
Yes, the
now?
one. Yes, one more person he needs to join. Just we can wait for just 1 more minute, else we'll start off.
Okay. Hello, Atta.
Hi, John.
How you doing?
And everybody.
Where's your picture? Atta, you need to be on the. We need to have your picture on the whole webcast.
Can you see me?
Yeah, we can see you. Hi.
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 Okay,
I'm
yeah,
Dr.
this is
Jyoti. Where are you from?
Right now, I'm in Geneva. I'm from Karachi, Pakistan,
Oh,
and now settled in Geneva.
okay.
And
Pleasure meeting you.
Yeah, you guys are basically gonna run this, okay? But we'll talk about that later. Atta, we're just gonna talk for a few minutes after the webcast, okay?
okay, sure.
Hello, Divya. Hello,
Hello.
Sevan.
Yes.
Yeah.
Good
Good
afternoon.
day.
So I think, yeah, good afternoon. Hello, everybody. A nice show, Divya. Good.
Yes, ma'am. Thank you, ma'am.
I think we are
Shall
on
we?
time, right?
Yes, ma'am. We're on time. Shall we start, John?
Yeah, sure. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. Good evening. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Tonight we have possibly the start of a dual neurosurgery community. And we have a gentleman that wrote me, Divya Giotti. He wrote me about starting a channel for dual neurosurgery, a topic which seems to be pretty hot. So I'll introduce Divya, and he'll basically run the proceedings. Good evening, Divya.
Okay. Thank you so much, John. Good morning, good afternoon, good evening to everyone who are joined from different parts of the world. Myself, Dr. Divya Jyoti. I'm consultant neurosurgeon at Yashoda Medicity Group of Hospitals based in Delhi, and I shall be the moderator and I'll be taking you through this webinar. So why are we here actually? As neurosurgeons, we encounter complex neurovascular pathologies every single day. And historically, the management plan has been limited to people trained in single modality, leading to a biased sort of an approach. Getting dual trained, okay. Getting dual trained gives us that extra bit of freedom to individualize the treatment protocol by being more patient-centric and comprehensive. Having said that, In this current era of endovascular practice, preserving and refining the microsurgical skills is of paramount importance. Today, all of us are here because we share a common belief that in order to have an unbiased cerebrovascular practice, we need more and more neurosurgeons to have good command over both the skills. And to achieve that goal, we need formal endovascular training as part of every neurosurgical residency curriculum across the globe. And for that, we need young dual-trained neurosurgeons serving as faculty in every possible teaching institute. So on this platform, ACONS, that's Alliance of Comprehensive Neurovascular Surgeons, we shall try to bring together all neurosurgeons across the globe who are dual-trained and who have that unbiased approach towards managing these complex cases. And the younger lot need to know the roadmap as to how to start off with the endovascular training, the places where they can visit in order to learn, people who they can talk to and seek proper guidance from. With this note, I would like to name one institute in India which has been at the forefront in training hundreds of neurosurgeons across the country in endovascular approaches through a routine residency program, a regular clinical fellowship, clinical observerships, hands-on workshops, and the name is GB Pant Institute of Postgraduate Medical Education Research based in New Delhi, India, commonly known as JIPMER or GB Pant Hospital, that has been catering to the medical needs of millions of people in northern India since 6 decades. And one person who took all the pain and hardships to initiate the endovascular program in JIPMER from the scratch was Professor Dr. A.K. Singh. He was the ex-head of Department Neurosurgery at JIPMER, currently the chairman and head of Max Institute of Neurosciences, Dehradun. Has he joined?
Yeah, we're going to meet Dr. Pashio, or who's presenting first?
Has Dr. A.K. Singh joined yet?
Well, who are you introducing?
I'll do that. I just want to just check out whether Professor A.K. Singh has joined or not.
Yeah, well, yeah, we have to see his face. Whoever's presenting, we have to see their face.
Let me check.
Simone, could you please come to the screen? Simone, who's presenting now?
I'll introduce.
I don't know.
I'll be introducing Professor Simone. Just a couple of minutes time.
Yeah.
Okay. So with the vision, probably Professor Singh would be taking a bit of time to join. So with the vision that he had seen.
Hello, Divya. Hello, Divya. Yeah, I think
Yes.
he's joined, but he's not able to open the video and all. Can you give him some different, as a panelist?
John, can you see Professor Singh in the list? Can you convert to him as a panelist?
Okay, so he's not in now. Okay, what's the name? What's the name that needs to come in?
John A.K. Singh in
A.K.
attendee.
Oh, Dr.
Professor A.K. Singh. That's the.
Okay, can you write the name down, please?
It's
Write the name
number.
down?
It's number 8 on attendee list. John, number 8 on attendee list. You can see it.
Okay, I need someone to type in the name, please, of who needs to be admitted.
Okay.
Okay.
Okay, who's going to type the name?
Just ask him.
Okay, H.A. Singh, correct? Okay. Just a minute, we're a little slow here. Sorry about that, A.K. Singh. Okay. Here we go. A.K. Singh should be coming in. Okay, Dr. Singh, are you in yet?
He's visible as A.K. Singh, Divya.
Just call him.
Okay. Dr. Singh, are you there? Sorry, folks.
Good
Let
morning,
me
it's
just
fine.
call him once.
Oh, there's Dr. Singh. There's Dr. Singh.
Morning, sir.
Okay, Divya, you're muted. You're muted, Divya.
Okay. So with this note, I would like to name one institute in India which has been at the forefront in training hundreds of neurosurgeons across India in the endovascular procedures through residency program, clinical fellowships, clinical observerships, and hands-on workshops. It's GB Pant Institute of Postgraduate Medical Education and Research based in New Delhi. And it's been commonly known as JIPMER or GB Pant Hospital, and that has been catering to the medical needs of millions of people in northern India since 6 decades. And one person who took all the pain and hardships to initiate the endovascular program in JIPMER from the scratch was Professor A.K. Singh. He was the ex-head of Department Neurosurgery at JIPMER, currently the chairman and head of Max Institute of Neurosciences, Dehradun. We welcome you, sir, to this webinar. And
Thank you.
And the vision that he had was carefully and meticulously carried forward for around 2 decades by another eminent figure in Indian neurosurgery, Professor Daljit Singh, who also was the ex-head of department at JIPMER, currently the vice chairman and head of neurosurgery and neurointervention at Max Hospital, Saket Smart, based in Delhi. Probably he'll be joining in a couple of minutes from now. Then we have the privilege of having amongst us the current head of Department of Neurosurgery, Professor Anita Jagatia ma'am, who has been the guiding force behind this initiative and is leaving no stone unturned in carrying the legacy forward in training and mentoring young neurosurgeons like me. And this platform and the webinar series is certainly her brainchild. Welcome, ma'am, to the webinar.
Thanks.
So now it's time to introduce today's guest speaker, although he needs no introduction. Dr. Simon Pescello is the professor of endovascular neurosurgery, Guglielmi Endowed Chair in the endovascular neurosurgery. He is internationally renowned for his expertise in endovascular treatment of cerebral and spinal vascular pathologies and minimally invasive cranial and spinal surgeries. Formerly associate professor at the University of Catania, and now the director of the European Master's degree in vascular and endovascular neurosurgery. He's also the co-director of the Neurovascular Center of the Ars Bio Medical Clinic in Rome. Professor Pescello has been a prolific researcher with over 100 publications in high-impact peer-reviewed international journals and has more than 1,600 citations. As a member of vascular section of ENS, the Italian Society of Neurosurgery, the French Society of Neuroradiology, he has delivered talks as invited speaker in over 100 international conferences. So without any further delay, let me invite Professor Simon Pescello to deliver the talk that shall inspire the young minds for years to come. Welcome, Professor Pescello.
Hello, good morning. Thank you, Diba,
Good morning.
for the kind invitation and for having me today with you. Yes, I would like to share this lecture about the history and the training program that we have in vascular and vascular neurosurgery here in Europe. Can you see my slides?
Yes, perfect.
Okay. So, yes, thank you for your kind invitation and for the brief summary of my activities. I am an endovascular neurosurgeon. I started doing this in 2008. I started my training here in Italy and in France, and then I'm following the tradition of the first endovascular neurosurgeon in Italy, who is Guido Guglielmi, who invented the Guido Guglielmi detachable coils. So to see and to discuss about the present, we have to take a look about the past. In this paper, we have summarized what were the most important milestones in the history regarding the vascular or in general neurosurgery. And what we have seen, for example, that the first reported surgery in humans history was the cranial trepanation in 2,700 years before Christus. And if you go along these milestones, we can see that in 1927, Antonio Egas Moniz was a neurologist, invented the cerebral angiography. And in 1937, 10 years later, Walter Dandy was the first neurosurgeon to clip an aneurysm. And along these important events, we can we have to see also the very nice improvement from Fedor Serbinenko in 1974. Serbinenko was a Russian neurosurgeon who introduced the era of the balloon of intrasaccular devices. And here just a couple of pictures that show you how was his setting and his angio suite. And this is an example of this treatment where he treated this aneurysm, this PICOM aneurysm with these detachable balloons. But the problem at the time was that these balloons were very stiff. So it was the risk of intraoperative rupture was very high. That's why they stopped using this. And till 1991, when Guido Guglielmi invented the detachable coils that were used for the first time in Los Angeles in 1991. So we can summarize that the pioneers of vascular neurosurgery are Walter Dandy in 1937 and Ghazi Yazagi, who passed away recently. But the pioneers of endovascular neurosurgery are Egas Moniz, when in 1927 invented the cerebral angiography, Fedor Serbinenko in 1974, and Guido Guglielmi in 1991. So if we put these important milestones in a timetable, we can we can see that the first clip were introduced in 1937, the microscope in 1974, the bypass in 1967, the endoscope, the use of the endoscope in the 70s, neuronavigation in 90s, Indio-Shanin green in the beginning of this century. About the endovascular side, we've seen that Moniz, Lucent over Velasquez, Serbinenko, and Guido Guglielmi were pioneers in this kind of treatment. And at the beginning of the 2000, the balloon introduction by Jacques Moret, the stent, flow diverters in 2009, and the thrombectomies at the end of the 15. So we have to keep in mind two important dates. March 23, 1937, the first clipping of a brain aneurysm, and March the 6th, 1990, when a detachable coils was first deployed in a human being. So let's take a step back about the training of cerebrovascular neurosurgeon. Who is a cerebrovascular neurosurgeon? Is someone who is dealing with open vascular surgery, with endovascular surgery, but also with radiosurgery. This is very important. And who is the specialist of the disease? No question about that. the specialist of vascular pathologies, of neurovascular pathology, is a neurosurgeon. And the specialist of the treatment could be an open vascular neurosurgeon or an endovascular neurosurgeon, or can be both, like in the hybrid model. So if we have to better define the definition of hybrid neurosurgeon and dual trade neurosurgeon. An hybrid neurosurgeon is someone who performs both vascular and endovascular treatment. A dual trained neurosurgeon is someone who performs or vascular surgery or endovascular treatments. But he or she has a background in the neurosurgery training. So, which is the future of open vascular neurosurgery? If we can take a look of this paper published in 2019 by Michael Lawton, they have discuss about the future of open microsurgery. For example, about brainstem cavernous malformation. Probably for the next year, the surgery for this lesion will increase. And what about AVMs? Nowadays, we know that open neurosurgery is the gold standard for Pretzler, Martin 1 or 3, and for most low-grade AVMs. And embolization treatment or radiosurgery can be used for AVMs in deep and inaccessible and eloquent location. And what about microsurgery for aneurysm? In the last year, we have seen a dramatically decrease of the surgery for these lesions. But what happened is that the number decreased, but the complexity of the lesions increased. I mean, nowadays, open neurovascular surgeons have to deal with complex, very complex aneurysms and bypass compared to the past. So, open microsurgery is and should remain a cornerstone of this of neurosurgery culture, because it offers anatomical insight and contact with pathology. Case volume is the secret of success because it develops experience, efficiency, and confidence. I've asked to ex-users which is the rate of nowadays of endo versus open treatment. And the answer of the majority was 90 endo, 10% open. Probably in Europe, the mean is 70-30. In France, for example, is 99% endovascular and only 1% open. But wherever it's the answer, there's no question about that. The present of the treatment of vascular pathology is endovascular treatment. So, as Charles Darwin has postulated in his book, The Origin of the Species, where, for example, the giraffe had the necessity to increase the length of the neck to remain to follow the evolution. In the same way, neurosurgeons have to develop and be more involved in the endovascular treatment. But which is the best method to train a cerebrovascular neurosurgeon? To be an hybrid neurosurgeon, or to be a vascular neurosurgeon, or to be an endovascular neurosurgeon? I personally have decided to be an endovascular neurosurgeon, to be more involved and in only endovascular procedures. But if neurosurgeons have completed fellowship training in only endovascular or only open surgical approach, they risk that they may have a bias or a limited option to offer to their patient. So neurosurgeons with dual training will be in the position to offer the best treatments and a full comprehensive approach to their patients. Nowadays, almost all vascular pathologies can be treated endovascularly. However, this does not mean that they should be all treated by this way. The discussion among the different specialties remain crucial, and there will always be a role for open vascular neurosurgery. But this will become increasingly limited. That's why the future of neurosurgery will inseparable from the future of endovascular neurosurgery. So we should stop fighting each other's open neurosurgeons versus endovascular neurosurgeons, but work all together to find the best solution. I would like to share with you this paper that was published in 2020 about the trends in the US about neurosurgery residency education and training. So let's take a look about the neurosurgery case log trends. And we can see that the arteriography and endovascular treatment had a dramatic increase in training, in terms of training for residents. That's very important. Let's focus the idea that the endovascular treatment must be part of the neurosurgical armamentarium. In this recently paper from Indian colleagues, they have summarized the feedbacks from Indians residents in neurosurgery. And what we have found, they have found, is that the exposure to endovascular treatments were inadequate for 80% of the people. So that's why we have to improve the training in endovascular treatments for surgeons and neurologists, for example. My dream is to work in a very comprehensive stroke unit. What does it mean? Where we can deal with ischemic and hemorrhagic patients, where interventional neuroradiologists and vascular neurosurgeons, interventional neurologists can work all together and do the best for the patient. What's next? We know that now the MMA embolization from chronic subdural hematoma was confirmed as a valuable option to treat chronic subdural hematoma. Endovascular treatment for glioblastoma will be the next step, but also the endovascular treatment of hydrocephalus, MMA embolization for headaches. So in the next month, not in the next 10 years, but in the next months, where the endovascular treatment will not be reserved only for vascular pathologies, but for many other neurosurgical pathology. For example, MMA embolization. We know that the occlusion of MMA is a very interesting option, especially for patients who doesn't need the bar hole or the drainage of the hematoma. Those are three of the main trials that were published in 2024. But if we need to drain and subdural hematoma, with this device, we can drain the hematoma and at the same time embolize the MMA. So this device will probably be available at the end of this year, and this device will change dramatically the treatment for this disease. Another chapter is endovascular neuro-oncology. I asked users in what will be the most important revolution in endovascular neurosurgery in the next 5 years. Endovascular treatment for gliomas was received the most answer. For example, this paper was published last year, and endovascular surgical neuro-oncology is advancing as a new subspecialty. And this is just like an example how now, and there are a lot of ongoing trials on how we will treat, for example, this glioblastoma endovascular with good results. And what about eShunt? eShunt is a brand new device to treat hydrocephalus via endovascular route. And just yesterday, Vitor Pereira from Toronto have published the news that they will start a very large study for this with this device, not only for subarachnoid hemorrhage hydrocephalus, but also for normal pressure hydrocephalus. That this completely will change the our approach to this disease. So whether we like it or not, this is not the future. This is the present. Lastly, I would like to invite you to join to 3 major training sessions that we are going to organize in Europe. The SNAC course is a surgical neurovascular angiography anatomy course that will be held in October in Rome. This is the website, snaccourse.com. We have an international faculty with Andreas Rabe, Giuseppe Lanzino, Michiro Tanaka, René Chapeau, Maxime Shapiro, Ethan Ras, and also Rahul Kumar from India. The learning objectives of this course is to master neurosurgical anatomy, to interpret and apply angiographic findings, and to introduce endovascular devices. This course is open to neurosurgeons who want to do endovascular treatments, or neurosurgeons who want to do open vascular treatments, but want to be more involved and want to go more deeply in the DSA findings, or to have a showcase of what are the endovascular devices nowadays. Also is open to neurologists, radiologists interested in endovascular procedures. This is another course that I am going to organize under the ENS, the European Association of Neurosurgical Societies. And this is a hands-on course especially made for MMA embolization. At the mid of September, always in Rome. And those are the brand new models, pro models that each participant will have to train to try to embolize the MMA. And finally, this is one of the most important projects that we have nowadays in Europe. And this is the European Vascular Endovascular Neurosurgery Master's Study Program. On the right, you have the QR code for the link for the website. It's open to specialists and residents in neurosurgery, neurology. Is 1-year course and is focused on practical training in OR on Angio Suite, and it will start at the beginning of November. And within this course, the attendees, we have more than 800 hours of practical and clinical practice in hospital, in Angio Suite, or in OR. Those are the 12 hosting centers across Europe that will offer you an endovascular training program, an open vascular training program, or hybrid program. I think that is a very important opportunity for young colleagues who want to be involved in vascular pathologies and in endovascular treatments. In the last editions, we had 1/3 of the attendees coming from India. So this is an European master course, but is open to all attendees from all over the world. We had Japanese, North America, Central America, South America attendees. So you are very welcome to join us. We have only 12 spots. The course starts November the 1st, and the deadline registration is on the mid of July. So in 10 days, we will close the registration, but we have only 2 spots remains. So if you are interested, please submit your registration as soon as possible. And finally, this is the NEVAD, the neurovascular cases discussion. 2 or 3 times a year, we are going to organize this completely free online platform where we can discuss about aneurysms, AVMs, dural fistulas, stroke cases, chronic subdural hematomas cases, and it's completely free. And wherever wants to present its own case, it is allowed to do this, of course. And we usually start from the Japanese colleagues, and we move to the West with Chinese colleagues, Indian colleagues, Middle East, Europe, and Americas. So the next session will be in October, and you are very welcome to join also for this interesting platform. And here in the bottom, you have the website for where you will see and you can find every kind of information. Thank you so much for your kind attention, and I am happy to answer to any question. And feel free to contact me to my email, simone.peschillo@gmail.com, if you have any question or you want any information about the courses and the master course. Thank you so much.
Thank you, Professor Simone. That was really a really inspiring one, and was quite enlightening especially for youngsters like us, to know the various fellowship programs and the training programs that you run, and that can be used by people. I would like to ask the chairperson whether they would like to have any comment on the topic.
Very comprehensive about the history and about how the future prospects for interventional radiology are looking up. We've had intervention for malignant brain lesions even earlier. We used to, long back in 60s and 70s, there was an arterial separation. We would separate out an artery. I think McDermott used to do that in England, and put in cyclophosphamide in the artery, the parent artery that was supplying the glioma. It had a lot of complications to stop. But I'm glad to learn that in future, we might be getting more interventional treatment, putting in the chemotherapeutic agent directly into the tumor. That's a very promising thing. We have still got no answer for glioblastomas. Professor Simone, that was an excellent talk. Thank you.
Thank you, Professor Singh.
Professor Simon,
Yes,
one thing I
Simon.
would like to know. Yes, ma'am, please go ahead.
Yeah, Simon, it was very, very excellent talk and very enlightening. Actually, this is in India, actually, it's a very big debate who should perform the endovascular and who should perform the, and that is I think that is the reason that you are finding about 80% people who are not doing endovascular and who are coming to you for the endovascular trainings and all. And main aim of this this webinar series, and actually in future we might convert this into a society, or that more and more young neurosurgeons, they should come forward to learn this, because especially in India, like country like India, when we have constraints of many economical constraints also, and we are very rich in terms of the patients, because even in the center like us, we are doing around 250 to 300 cases a year of vascular. And Chandigarh, like PGA and all, they are doing even more, like 500 cases a year of vascular, excluding the other indications like MMA or glioma and all other things. So in those terms, we are very rich in this. And um, you see, as you said, that we are also getting many complex cases than the simple cases, because the simple cases are being treated at the periphery level. Even in India, it's not, we are in India, at the periphery, the people are working on the C-arms with the roadmap facility, because it's not possible to have cath labs at every place, but they are giving good clarity, good visibility on C-arm with roadmap facility also. So it's a good initiative by Divijyoti, and hope in future we will be able to do the justice with the treatment, what kind of treatment is actually best for the patient. Yeah. Thank you.
Okay, Professor Simon, one thing I would like to know, that over the years we have been seeing a tremendous rise in the number of endovascular hardware. Almost every 6 months we find an exotic hardware, and Europe has been at the forefront of approving hardwares ahead of other countries. Now, how has that affected the microsurgical training practice in Europe, and also in the long-term patient outcome as well?
Well, this is a very good point. One of the major issue of the microsurgery is that even if now there is a new an improve in the bypass technique and in bypass cases, compared to the endovascular approach, where every month we have a brand new device. Now we can offer every kind of treatment that we want to vascular patient. I mean, nowadays probably endovascularly we can treat 99% of the cases. But the big question is which is the risk to treat a patient, for example, with a large neck MMA MCA aneurysm, endovascular versus open vascular, even if this patient is a young patient. So we have always balanced the procedural risk and balance this with the age of the patient, the location of the lesion, and then we can choose the best treatment for this patient. I strongly believe that young neurosurgeons might trained also in endovascular procedures, even if they want only to do open vascular procedures. Because the endovascular treatment is part of neurosurgery. It's not something that is outside neurosurgery. For example, in Japan and in Americas, neurosurgeons are the most specialists that are dealing with the endovascular treatments. In Europe, unfortunately, the majority of them are neuroradiologists, and there are very few neurosurgeons. But this will change in the next month. ENS is strongly supportive in this. And as a member of the board of ENS vascular section, we are working hard to offer these endovascular courses, these hands-on training courses, just to offer the first step for to young neurosurgeons to be more involved in this kind of treatment. And then, if they want to be more involved, the idea is that they have to participate of one of the master course, for example, that lasts 1 year. And in 1 year, for a neurosurgeon, is good enough to have the basis for to do a DSA, to do a thrombectomy, or to do, for example, a simple aneurysm case.
Excuse me, Divya, do you mind if I make a comment? Yeah, I'm Dr. John Bennett, head of Neurosurgical TV. I'd like to introduce at this time Atta Bhatti. He's a dual neurosurgeon from Switzerland, and he's going to be representing Neurosurgical TV in the dual neurosurgery category. Hello, Atta.
Yeah, hello everybody. Simon, excellent and balanced perspectives. And I'm thankful you just focused on the clinical front. So I totally agree that there are many political issues, licensing and clinical practice. So maybe at one front we are overtraining the numbers, but it's the quality which prevails. So yes, numbers are important, but having just supervised work with a quality and the basic selection. So from the patient's perspective, there are certain missing things. Like when he sees a neurosurgeon in a fragmented practice and a neurointerventional person, sometimes they both are not willing to express their opinion in a unified way or under the one roof. So that creates another psychological burden for patients and families, because people are biased towards the way they are trained, and resultantly there is more chance that they end up getting the treatment what clinician is imposing on based on their own biases. So having the input from both in the form of either hybrid or a very good aligned team is something which is desperately required. And yes, I see the histories showing neurologists or neurosurgeons in the forefront, like Egas Moniz invented the diagnostic skills, and then clinicians. So I was being trained as a fellow with Valavanis, and he was not only a neuroradiologist, he was keen clinicians going into depth of the subtle changes, and that was his skeptical clinical instincts which make him outstanding in AVM treatment. And at the time when whole world was reporting just 10% exclusive endovascular treatments for AV malformation, his series of 700 plus were showing 40.2% exclusive treatment of AVMs, including the most special grade 3, 4, and 5 cases. So but credit goes to his clinical training his clinical way of practicing. And I remember he telling in front of Professor Yashir Gill the way he treated. He spent hours standing in operating room on the other side of Professor Yashir Gill's microscope to see the actual contact. What you mentioned in your one of your slides, that the pathology contact with pathology. So he was part of that. So the training should be done by a balanced faculty or with focus to target to treat the disease rather than having this confrontation amongst the team members. So that's something which is desperately required. For the newcomers, I think Dr. Debia is lucky enough to have Professor A.K. Singh and Professor Debia and the neurosurgery chief, Professor Anika. So he's getting enough support. But every new trained dual neurosurgeon is not lucky to have that support. So when we start training, we get the most resistance from our neurosurgical colleagues back home. So that's one thing. So we have to understand that having this extra skill after a microneurosurgery exposure is going to benefit whole system, and most of important thing is benefit to patient. So there are reportedly new cases, a wave of those which treated earlier with the endovascular, and later they had recurrence, like uh, like uh, uh, recurrence within days or within a 1 year time. And those cases are really difficult because every next attempt is going to be a make or break. So having a balanced exposure is going to be beneficial. Having a liberty to see all the stakeholders under the one roof is going to save the time on the perspective of patient and families. So there are many links which are still needs to be uh, mm, defined in real world. So I'm very excited to see your efforts bringing in a lot of training and political voice in EANS. Thank you.
Thank you, Arthur.
Thank you. Thank you for those insights and for that nice lecture. Now, hopefully, moving ahead to the next session, we have something sort of called vascular board, where we have with us Dr. Binita Dholakia. She's the assistant professor, Department of Neurosurgery at JIPMER. She'll be discussing a couple of cases that the team have done it, and would like to have views of the panelists on what they would have done if they had that case in their hands. Go ahead, Dr. Binita.
Hello, everyone. Continuing with today's session, here are two cases which highlight the importance of comprehensive neurosurgical training. I'm now going to share my screen. So, is it visible to everyone?
Not yet.
Yeah, the first case is an M1 segment aneurysm. A 44 years old
Excuse
female
me,
presented.
are you going to share? Are you going to share the PowerPoint?
Yes, I'll be sharing the PowerPoint.
Oh, okay. You're not sharing it yet. Okay.
It's visible, right?
Yeah, not yet. Click
Not
on the
yet.
share first. Share the first. There you go.
Is it visible now?
There you go. Okay, perfect. Perfect.
Okay. The first case is of M1 segment aneurysm. A 44 years old female presented to us with sudden severe headache, SH, Hunter's grade 2 and modified Fisher grade 3. The CT scan is on your screen. To plan the case, we proceeded with CT angio brain, which was suggestive of a lobulated outpouching measuring 5 by 8 mm from M1 segment of right MCA with reactive attenuation of adjacent vessels. To further delineate the morphology of the aneurysm, here is the cerebral DSA. So I would now like to ask the panelists how would they proceed with this case, starting with Dr. A.K. Singh.
So see the lateral view. Show me the lateral view also.
So unfortunately, this is the only view we have at present.
In that event, you'll have to give the option of both endovascular as well as surgical to the patient. It's relatively easy from both sides. For an endovascular, you'll have to put a stent, I think a stent assisted coiling. Surgery, this should not be much of a problem because it is away from the main feeders, main perforators.
Okay, sir.
So
Now,
what I would offer the patient would be both options.
okay, sir. Now, continuing with Dr. Anita.
I see that there is proximal M1 is a spasm, and the intertemporal artery is arising, and there are reticulocyte perforators also I am seeing. Of course, if you think that both the options are available to this patient, but the problem with the endovascular is that, as Sir said, Dr. Singh said that it will require the stent to occlude because the neck is very wide. But there is risk of occluding the temporal as well as the lenticulocyte perforators. So, but those can be managed when we open up this case and do the clipping. So that is there.
Okay. Professor Simon, your views?
Yes, thank you, Benita. That's a very interesting case. I think that we should take a step back and to understand what kind of lesion is that. Probably this is a dissecting aneurysm, and that's why, in my opinion, a stent is definitely a good option. And probably I would treat this lesion with stent and coils.
Okay, Professor Simon. Now I would like to share what we did. Keeping in mind the location and morphology of the aneurysm, as well as age and presentation, she was taken up for microsurgical clipping with aim to obliterate the aneurysm completely. Intraoperatively, aneurysm was found to be thrombosed, arising from lateral wall of M1, 1 cm distal to ICA bifurcation and 0.5 cm proximal to MCA bifurcation. This is the intraoperative video. So as you can see, it was extremely difficult to clip since the vessel wall was also inflamed, and ultimately the procedure had to be abandoned. We tried clipping with these ways, but it was not possible in any of these ways. So next, she then underwent stent-assisted coiling with Enterprise 4 by 30 mm stent and GDC coils. As you can see, this is the post-procedural DSA. So before proceeding to the next case, would we like to discuss this case any further?
Can I comment on the last post endovascular? Yeah. So can you run this video?
Yeah.
If you see that the anterior temporal is not filling up, So the stent if these kind of cases when you are putting the stent, that is the risk which we are seeing in this case also. We are not seeing the anterior filling. Although it is nicely filled, nicely coiled, good stent, and even the proximal part is also opened up. What we discussed, that proximal there is sparse and there is some narrowing, but temporal is definitely filling. So that is a risk when one undergo stenting for these kind of aneurysms, where you have the small branches arising. They may operate. That is what I'm seeing.
Yes, thank you, Dr. Anita, for your views. And on 2 years follow-up, I would like to share that the patient is doing perfectly fine. Proceeding with the next case, we had a multiple distal ICA aneurysms with an AVM. She was a 32 years old female, presented to us with the GCS of even V1M4, Hunt has grade 4, and modified Fisher grade 4 status. On DSA, we could see 3 aneurysms and a distal AVM, 1 aneurysm in the upper trunk, 1 aneurysm in the lower trunk, and a small blister aneurysm in the cortical branch. We worked her up for vasculitis profile, which turned out to be normal. This is the supraselective shoot of ICA vessel showing all 3 aneurysms and distal AVM. Again, I would like to know the views of the panelists. How would they proceed with this case? Starting with Dr. A.K. Singh.
I'll probably go for interventional all 3.
Sorry, sir?
I'll go for interventional for all 3.
Okay,
interventional.
sir. Okay, sir. Dr. Anita.
And go for open because it is very distal. You will have short microcatheters, even if you take the microvention duos, which is the longest, I think. And aneurysm morphology is not good. You wouldn't be able to deal with the dural AV communication also. What you're calling is as AVM. And aneurysms are also fusiform, so it's not a good case for the aneurysm.
Hello, Dr.
Thank you.
Bhatti. Dr. Bhatti, can you comment? Are you there, Atta?
Yes, I think it's a case for, to me, it's a case for open treatment, and I would be more skeptical for AVM, and there is a possibility that the one or all may be related to the flow, and treating the AVM can settle down the aneurysm. And while approaching this AVM, this cortical one was looking more fragile by the shape, and they are more accessible in a one approach. So I would consider treating the too fragile one and AVM with the open approach.
Yes. Professor Simon, your views, please.
Yes, very tricky case. Probably I would treat endovascularly because this is a rupture AVM, but the rupture comes from one of these aneurysms. The big problem is understand who of them is the reason of the hemorrhage. The big problem is that the first one, the very proximal one,
Yeah.
it's
one.
near the origin of the vessel. So from there are a lot of perforators that comes from there. So probably I would use a balloon for a balloon occlusion test. And then if the balloon occlusion test is good, I would probably occlude all from the origin the vessel.
Okay, you would proceed with parent vessel occlusion.
Yeah.
Okay, so now let me share what we did with this case. Owing to the distal location and tortuosity of the vessel, as Dr. Anita said, we proceeded with a flow diverted microcatheter headway duos, which is 167 centimeters in length, to selectively cannulate the ICA trunk. We were only able to do the selective partial coiling of the lower trunk aneurysm with failure to pass the microcatheter any further or into the upper trunk, and the procedure had to be abandoned after multiple attempts. This is the video. See, as you can see, we are not able to pass the catheter any further.
May I say something here? The big problem is that
Yes.
you have not enough support from this microcatheter. So where is your guiding catheter? It's very low. So you have enough. You don't have enough support to push more distally the microcatheter.
Yes, sir, that was an issue. We even tried to take the guiding catheter further, but still we were not able to cannulate the trunk or pass the catheter any further. It was probably due to the narrow caliber of the vessel, sir. So fortunately, the neurological status of the patient improved, and then we took her up for MRI with MR angio to locate the aneurysms in respect to cisterns and anatomical landmarks and plan for clipping. This is the MRI showing the location of the first aneurysm, and this is the location of the second aneurysm. We then proceeded with right-sided RMSO craniotomy. This is the upper trunk aneurysm, which was found to be directed superiorly, clipped using 7 mm upcurved clip, and patent distal flow and absent aneurysmal flow was confirmed on ICT videography. And there was no kinking of the parent artery as well. This is the lower trunk aneurysm, which was partially coiled. It was clipped using 5 mm straight clip. We did aneurysmotomy, and the coil with thrombus was removed. Post-ICT clipping showed patent distal flow with absent aneurysmal flow. This is the close-up view. The cortical blister aneurysm was wrapped, and the small 1 centimeter nidus of AVM was excised, which was present just underneath the cortex. This is the post-procedural DSA after 1 week. Here we can see that the ICA is patent with complete obliteration of all aneurysms and AVM. And to rule out the possibility of mycotic aneurysms, the wall was biopsied and cultured. We did not show any evidence of vasculitis or infection. The postoperative course was uneventful, and she was discharged without any deficits. Comments from the panelists, please.
Congratulations, very nice case.
Dr. Singh, you're muted. You're muted. You're still muted, Dr. Singh. I don't know what's going on. Okay, the next question or comment, I guess. Because we can't hear Dr. Singh, even though he looks like he's trying to talk.
I'm here.
There you go. There you go.
I said that this is a very nice outcome, and glad that you tried both, which is what makes it very relevant. The main thrust of the seminar, the webinar, being that you should have both the capability of intervention as well as microsurgery. This proves it very well.
Yeah.
Great.
I have a question from Simon. You said you wanted to take the guiding right up to the VA, goes up to the origin of the like ICA, proximal bacil. So, do you find any time that your microcatheters are short in length, like or what microcatheter you would like to take in this case?
Sorry, Anita, can you say it again? Because I had a technical issue that I cannot hear you.
Yeah. So sometimes taking the even distal access catheter is also difficult to take right up to the basilar. Sometimes, definitely. So, and in that case, the length of the microcatheter gets shortened when the aneurysms are distal, or even for that matter, the AVMs also. So, do you have any specific microcatheter for these kind of cases? Like we do use micromention duos, which is longer than any other microcatheter. So,
Yes, thank you. This is a very good point. Actually, all the microcatheters that we can use for AVM embolization are longer than 165 centimeters. But from BALT, we have also a catheter that is longer 190 centimeters. But I think that in this particular case, probably I would use a guiding catheter with the distal tip that is very soft and is longer than the majority of the guiding catheter. So then you can move around the loops of the vertebral artery, and you can go more distally, because here you need the most distal proximal support in order to be able to push more distally the microcatheter. So my suggestion is always or to use a longer guiding catheter or to use a triaxial system.
Okay.
so
A distal axis.
how would you have? Yeah, how would you have assess the balloon occlusion and the function and ICA?
Yes, we know that at the origin of the ICA, PICA, we have a lot of perforators. The big problem in this case, for example, is to balance the risk of occluding the PICA against the risk to have an ischemic lesion. But if the balloon occlusion test goes well, you in one shot with a drop of glue, you can treat all the 3 aneurysms along the vessel, and then thinking about the AVM. But at that time, the major risk was to have a new hemorrhage. So that's why I would focus on the aneurysms treatment.
Right, thank you.
Can I
Thank
ask?
you.
Can I ask something, please? How do you plan to follow up this case?
Yeah. Hello.
Go ahead. Go ahead, Arthur. We didn't hear your question, Arthur.
Yes. Can Dr. Vinita, how are you going to follow up this case? Can you please share your plans?
So this is the follow-up angio after 1 week, and presently the patient is with us in follow-up since 2 years, and we did follow-up MR angio also, which showed patent ICA and no evidence of aneurysm or AVM. Is it visible? The follow-up DSA is visible?
Not yet.
Yes, sir.
Ladies and gentlemen,
this
I
is how we
apologize,
followed up, sir.
but I have to go.
Okay, thank you
Thank
very much,
you, Dr.
Simon.
Thank you, Dr. Simon. Thank you for joining.
Thank you so
Thank
much
you.
for your kind invitation, and
Thank you, sir.
I hope you
Thank you, Simon.
to
Thank
see
you.
you soon.
We'll be in touch.
Thank you,
Absolutely,
Simon.
yes.
Thank you.
Thank
you
you.
so much.
Okay,
Thank you,
you.
Simon.
Okay, Divya, let's continue on.
Yes. Just before we wind up, I just would like to ask Professor A.K. Singh to actually share his. Actually, it's been 2 decades since the start of the endovascular program at GBPath. I would ask Professor A.K. Singh sir to actually, if he can share some of the hurdles that he faced while initiating this program, at GB Pant Hospital, so that we as young neurosurgeons can actually gear up ourselves, whoever is planning to start such a program in his hospital. Please, sir, can you just share some of your moments?
In 2004, that's 21 years ago. See, I did my training almost 50 years ago. I joined neurosurgery training program in 76 January. Till about 82, there was no other option other than angiography and ventriculography and myelography myelography for locating and diagnosing neurosurgical or neurological diseases, tumors, etc. So I was trained only on angiography. So when I came to Pant in 81, we had what we used to call a machine called Elima Shananda, in which we had to manually move the arm on either side and take out the X-rays manually, and then develop them the old way. That is a wet development. We continued with that. A CT scan actually became available in Pant much later, but outside it had become available. In 81, it had, I think, 78, 79 or 80, it became available. The first CT scan of the country became available in All India Institute. Thereafter, in the private sector, Dr. Sehgal had put up one, and I think we got ours in 84 or 85. So till then, we had only angiography and ventriculography for locating lesions. And then subsequently, in 90s, the first MRI of the country became available in mass. In the beginning, none of us knew how to correlate the anatomy on CT or MR. So when we actually got an MRI done, we would come back and do an angiography or a myelography to ascertain, because we were used to that. So it continued for a long time, and we had it with us. But once the CT became available, then there was that option that you might as well leave doing angiography. We continued doing that because by that time, reports had already started appearing from the West in the journal that interventional work was starting. So that seemed to be a thing that we had long discussions in Delhi Neurological Association. And every time it came down to this thing, whether surgery or embolization, Dr. Sehgal's final word used to be often that if I had it, what would I do? Would go for intervention rather than surgery. Now that prompted us to continue doing this. In the meantime, the first one of us from our center to have gone for further training was Shakir Hussain from neurology, who went to Zurich to undergo training under Professor Valavanis. He came back and he joined at, we couldn't take him in GB Pant, so he joined at Gangaram. And he started doing embolization. Prior to that, whatever embolization we were doing was in KGMC from where I was. We would actually do it in the external carotid. Meningioma or scalpavium, we would isolate the external carotid artery, put in a catheter inside, use muscle or silk for embolizing, and then tie off the vessel. We obviously couldn't do it in the internal vessels. So for external vessels, that is what we used to do. So that embolization was something that we had been doing even earlier, in 70s, 80s earlier. The transfemoral angiography in Pant started sometime, I think, towards the second half of 90s. Right? What had happened was that our radiology department had got a machine for doing cardiac angiography. Right? They started doing cardiac angiography, but the coronary angiography, simultaneously, the cardiology department had got their own machine. So therefore, the radiology machine was left unused, which we got to start doing. And our transfemoral angiography and intervention started there. And the person who was doing that there was Shakir and Daljit. Right, so Daljit was the first one who started doing the intervention work. He agreed to do this because I needed a young chap to do that rather than me. I was there because of my previous, experience of diagnostic angiography. I was quite good at reading angiography. So for reading, I was there, but for putting in the catheter, etc., and the embolic material was Daljit and aided by Shakir. So that's how we started. This was in the later half of the 90s. And gradually then it went on. Now, of course, all of you are doing it. Great. Great to
Can
know.
I just compliment your work started in so much difficult era, and it's excellent to see how the growth is there. I personally know the quality and the work of Shakir, and uh, the one of the adding this all discussion, one of the main areas neuro ICU care. So if we look back from the Fisher's experience to Yashagil and later on in the current era, what has given the tough time is the ruptured pathologies, especially the ruptured aneurysms. So neuro ICU care, it makes the neurosurgeons more relevant on the driving seat. So uh, for example, the spectrum of endovascular is increasing, but the decision matters when to intervene for vasospasm treatment, how we treat and switch to the other modality, and this dual neurosurgery owns the patient. And many places, the radiologists not trained in the clinical neuro, they are taking the calls, but they don't have ever seen the patient in emergency rooms. They don't have uh, contact with the neuro ICU care process. So uh, what I focus is the success lies in the teamwork in the neuro ICU care, and also having a very uh, a team which knows each other, and the nursing staff and paramedic also comes into essentially important key decisive factor for the clinical outcome, and the communication, of course. So we learn from the giants who work in a global or in a local perspective. They started with a very minimal technology support, and they did very safe practice. They took the ownership of long-term management process. So what I learned from my seniors is this way: to have ownership, as you mentioned, that to make the decision considering that if it was me or my family member, and training our whole team. That's something which will prepare the system, whether it's in emergency department or it's in neuro ICU care. Obviously, the complication rates will not become zero even in the best hands. So that's the one reason why people don't want to come into neurovascular. Thank you.
Okay. Thank you, Dr. Bhatti, for your views. And thank you, Professor A.K. Singh. So that was really inspiring. And certainly one can script a movie on that based on that story. Now, coming to the end of the webinar, I would like to thank everybody who have joined in, all the chairpersons, all the speakers, and all the attendees. Probably these are just the baby steps that we can take it ahead. And to be honest, it's my dream that one day every teaching institute across the globe should have a formal endovascular training. Looking forward to your support in future as well. We'll be coming with the next webinar next month. I'll disclose the dates very soon. And thank you so much for joining.
Okay, we'll talk more about that, Divya, but an excellent first introductory program. And Dr. Singh, thanks for joining. Atta, thank you. Vanita, Anita, thank you all for joining. I left a chat invitation for everybody, including Dr. Singh. Please join our chat group. I put it in the chat, the address to join our WhatsApp group. It's a chat WhatsApp group for dual neurosurgery. So put your thoughts in there anytime about what you want to hear, what you want to see, what you want to contribute to dual neurosurgery, etc. But it was very lucky that Divya approached me at the right time, and we're going to make this work and improve education in dual neurosurgery. So thank you all for coming, and we'll let you know when our next visit is going to be. And hang around if you want. I'm going to go off the air. Thank you.
Thank you.